Thank you very much for your interest in this webinar presentation on mechanical low back pain. I'm Kent Timm, Managing Director of the Saginaw Bay Road location for Renew Physical Therapy. We're going to be talking about some things related to mechanical low back pain. I'm sure that's an area of interest, and you'll see why, at least statistically, as we go on in a little bit. This is basically a revision of a program that I was asked to I was asked to present at the at the Central Michigan University Medical School a couple of weeks ago for the family practice medical students and for the family practice residents as well as the faculty. So I'm presenting to you here today similar information that was presented to them. This is not me coming up with stuff. This is me as the messenger trying to relay the information that is out there in terms of the genuine cutting edge knowledge, science, and clinical practice guidelines for dealing with mechanical low back pain. As we go on, if you have questions, there is a question and an answer box off the Zoom program. Please feel free to log in your question and we'll make sure we try to get it answered at the end or by the end of the presentation. If for some reason that's not working and you have questions that you think of after the end of the webinar, the last slide or so will have contact information where you can get a hold of me to hopefully get the question answered. So as we go on here, we have some learning objectives. And this is going to be, here we go, what we basically are going to try to talk about in this presentation is looking at the single primary cause known in fancy medical terms as the biomechanical origin of most cases of mechanical low back pain. And out there you may see this now abbreviated as small m, capital L, capital B, capital P. M, the small m meaning mechanical, L meaning low, B meaning back, and P meaning pain. There are other non-mechanical entities that result in low back pain, but we're not going to, we'll allude to some of them, but that's a whole other topic, maybe for a future webinar. We're also going to talk about how people actually get a disc herniation or a ruptured disc or a slip disc. All those terms are somewhat interchangeable. We're also going to talk about the current red flags. And this relates to the area of imaging, X-rays, MRI, CT scans, and things like that. There's a lot of controversy and there's a lot of misunderstanding out there about who needs what. And this is me being the messenger based upon information from the people who have done the science, who have the expertise to make such decisions. Not everyone with back pain necessarily needs an X-ray. Not everyone with back pain necessarily needs an MRI. Not everyone who has an MRI is going to find the source of their mechanical low back pain. And X-rays or MRIs are not necessarily needed prior to the start of treatment approaches. And finally, we're going to talk about the single least effective method of treatment, which unfortunately still has the most or the highest level of actual application out there in the real world, at least across the United States. So let's go on and talk about some things here. The operational definition, which is the fancy way of saying, when we say mechanical low back pain, this is what we mean. Mechanical low back pain has been defined as pain arising from the vertebral segments, the fancy way of knowing the actual bones of the back, the intervertebral discs, those discs which slip or herniate, which are located structurally in between the bones of the back, or the surrounding soft tissues, the muscles, the tendons, the ligaments, the fascia. Now this operational definition is actually agreed upon by the surgical community, by the medical non-surgical community, by the osteopathic community, by the chiropractic community, and by the physical therapy community. So this is the current definition out there. So whether you have back pain or whether you seek the services of your family practice physician or a specialist or a neurologist or a neurosurgeon or a chiropractor or an osteopath, this is what we're talking about. So there is agreement in terms of what we mean by mechanical low back pain. So as we go on, we want to talk about, or we want to mention something called epidemiology, which is a fancy way of saying the state of what's really going on out there, at least in the United States. There is international data, but we don't practice outside the United States, so let's keep things in the United States. In terms of incidence, in the United States population, the current data shows that there's an 85% chance of any and every American experiencing an episode of mechanical low back pain within their lifetime. 85% of Americans are going to experience an episode of mechanical low back pain at some point in their life. Now, by episode, we're talking about a situation of symptoms lasting at least 2 weeks, where there is some degree of decrease in their activity. This would mean not being able to do what you normally do. This would mean interfering with your ability to do what you do on a normal basis, whether it's work, whether it's picking up around the house, whether it's driving to visit a friend. This is what we're talking about. Now, in terms of prevalence, the information that's out there is that 23% of Americans have low back pain at any given time. So here today, on Wednesday, October 28th, 2020, 23% of the U.S. population, and the U.S. population's above 350 million people, have mechanical low back pain at this time. At least that's based on the data that's been collected from a variety of professions for a very, very long period of time. So those are some high numbers in terms of incidence and prevalence. The good news is most cases, 80% of cases of low back pain resolve completely within 6 weeks. Now you might think naturally, for those of you who are suffering low back pain, and I've had cases myself, when I've had low back pain, it's like, well, it's going to be better in 6 weeks. Well, it hurts now. I don't want to wait 6 weeks, and that's a realistic expectation. But the reason why we say this is that even though it hurts, even though you may not be able to do what you want to do or normally do when you have an episode of mechanical low back pain, the good news is there's an 80% chance that 6 weeks from now, it's going to be completely resolved and you'll be back to your functional normal and be able to do what you want to do and need to do. The key to treatment, of course, at least in terms of physical therapy, in terms of medicine, in terms of chiropractic or whatever, is to try to shorten that period of time in terms of getting you from low back pain to no low back pain in less than 6 weeks. Information out there in terms of what causes it or what predisposes it, because there are many causes. There's many causes that you can think of. But in terms of predisposition, those folks who are exposed to situations where you have to lift and twist, like basically pulling something off of a pallet and moving it to a higher shelf, this sort of lifting and twisting predisposes low back pain. Or moving, lifting, twisting on an assembly line predisposes low back pain. Also, situations, jobs that involve a lot of vibration. I'm just kind of vibrating here to try to look like this, and not a whole lot of us are subjected to vibration, but maybe we are. If you have an older model vehicle whose shocks are shot, you're going to have a lot of vibration. If you're an over-the-road trucker, you have a lot of vibration, no matter how ergonomic your seat is or how contemporary the technology is, you're exposed to vibration. Conversely, People who sit a lot, prolonged sitting predisposes mechanical low back pain. So it's almost like, well, goodness, we can't do a whole lot of things. We can't lift and twist. We can't do things where we're vibrating. We can't sit for a long period of time. Well, realistically, all those factors contribute to the development of low back pain. What's also known is that the cost of treatment of just this type of problem currently exceeds $100 billion on an annual basis. And those costs are across the board. And certainly it's a very expensive proposition, and it certainly can be something that is only going to get worse, unfortunately, as we get more people in the country and more people not doing things to hopefully prevent the development or prolong or try to shorten the treatment period for resolving low back pain. Okay, let's go a little bit more into epidemiology. We can break things down a little bit more. When you take a look at, I'm going to back up one slide. When we take a look at these prevalence statistics, 85% episodes, a chance of an episode in your lifetime, 23% at any given time. When we break those down further, 70% are from muscle strains. It's not good that you strain your muscle and create pain, but what's good about this, if you can find some degree of optimism, is that muscle heals very nicely and with minimal residual effects. So if you have a case of mechanical low back pain, just playing the percentages, 70% of that chance is a muscle problem, which will respond very nicely to more conservative measures. However, drilling it down further, we have to look at disc injuries. Disc injuries are out there, but they're not as prevalent as people would have you think. The chance of having a disc injury is actually relatively low. It's at only a 10% chance versus the 70% chance of a muscle strain injury. And going further down in terms of some other sorts of situations that involve the bones or part of the bones, there are phenomena known as spondylolysis, where you get some irritation and some problems with components of the vertebral body, fractures or compression fractures, spondylolisthesis, which is a slipping of one vertebral body on another, and then finally spinal stenosis. Spinal stenosis is an issue because this is a scenario where you get a narrowing of the tracts through which either the peripheral nerves going down into the legs move through, causing problems, or you get a narrowing of the tract that the spinal cord itself moves through, causing problems. So we've got to be respectful of all these potential causes. But again, playing the percentages, 70% of the time you're going to have a muscle problem. Yes, it hurts, but it should resolve itself and it will not result in any kind of long-standing or permanent disability. Now, why do all these things occur? The work that's been done has shown that here is the primary biomechanical determinant, and that's the thing known as the lumbar lordosis. The lumbar lordosis is the natural occurring curvature in the lower back. In this situation here, and hopefully the pointer works, and it's unfortunately not going to, but in the slide here, you can see an angular relationship. This is a view or a diagram of the lumbar spine viewed from the side. In this case, the person is facing to their, or to your, as you're looking at this, to your right. So they're facing to the right, you're looking at them from their right side. The big thing at the bottom is the sacrum, or S1 as they call it, the tailbone. On top of that is L5, the lowest lumbar vertebrae, and there are typically 5 lumbar vertebrae. There are 3 angular relationships here that define a normal lumbar lordosis. And if these 3 angular relationships are present without any sort of change beyond 3 degrees, you're going to have a normal lumbar spine, you're going to have normal mechanics, you're going to have normal tissue structures, you're going to be pain-free, at least from mechanical low back pain. But if any of these angles are changed through movement or through trauma or through poor posture or some prolonged sort of situation where your lumbar lordosis is not in its normal biomechanical relationship, you're going to set the stage for mechanical low back pain. And this is it's a nice to know this situation. This is the origin of the problem, but it's not very practical, unfortunately, to check on this because this would require a standing x-ray. And a standing x-ray is a very nice static picture of the person's biomechanics and anatomy. But a static picture doesn't transcend into dynamic function. So the key is not only how does the lordosis look or how is it functioning when you're standing there looking at it from the side, but more importantly, how is it functioning with dynamic everyday movement and activity? And if for whatever reason these angular relationships are being disrupted for periods of time, that sets the stage for further problems. Okay, a lot of science here, a lot of situations, but this, if nothing else, is the underlying cause of things. And again, if you have questions about this or concerns about this or would like more information, just please access the question through the chat function, or there'll be a slide near the end where you can find the contact information to get a hold of me directly. Okay, what's a little bit more interesting, and as I mentioned before, this is similar to a talk I was asked to present for the medical school students and faculty. So it's a little busy and can get a little bit confusing if you're not really interested in the anatomy and the physiology. There is a set sequence of things that result in actual injury to the disc. Now, on the right side of the screen, it's meant to depict diagrammatically, if nothing else, how a vertebral body or a bone works above and beyond the circular thing, which is the intervertebral disc. The actual circular thing in the middle is called the nucleus pulposus. That's the stuff that slips or herniates. The stuff on the outside is called the annulus fibrosus, which is basically kind of like a tendon or a ligament that keeps the nucleus in place. What happens first as the sequence of events that leads to mechanical back pain from disc injury is some degree of an abnormal lordosis. Again, backing the slide up, here's the normal lordosis. If something disrupts this or changes these angular relationships, that's the first step toward disc injury. And you can't really see this, and I can barely see it, and I'm looking at the master slide. There's something called the vertebral end plate. The vertebral end plate is a layer of cartilage that overlies the intervertebral disc. It's very similar to the cartilage that overlies any bone in a typical joint in, say, the knee or the hip or the shoulder. It's the type of cartilage, very similar to the type of cartilage, that if it deteriorates in, say, the shoulder, you end up with arthritic changes. Or if it deteriorates in the knee, you might end up with the need for a total knee replacement. But when it deteriorates in the back, in the lumbar spine, what happens is the material from the nucleus pulposus, the inside of the disc, is allowed to move upward or downward into the bone above it and below it. This is what's called a Schmorl's node, named by Dr. Schmorl, who way back when first identified this kind of situation. So you have the annulus starting to actually protrude or herniate upward or downward. It's called a vertical herniation. It can be upward or downward. What happens then is that the material in the nucleus pulposus interacts with the blood supply and the bone cells within the vertebral body, either above it or below it, and this sets off a chemical reaction and an autoimmune reaction. And the reason for this is that the contents of the nucleus have a little bit lower, they're a little bit more acidic in terms of pH. The normal pH of the body is about 7.4. The normal pH of the intervertebral disc, the nucleus pulposus, is about 6.8. Now that's not a huge difference, but when you have something that's a little bit alkaline, 7.4, which is the environment of the intervertebral disc, the bone, and the capillary beds, come into contact with something that's a little bit acidic, you're going to get a chemical reaction. And that chemical reaction will cause an irritation of nerves, which are meant to be represented by the small sorts of things in this diagram. And that's where you start to get actual pain. This would be pain that is centralized just on the spine itself. And this is an inflammatory process that, if not corrected, is going to only worsen things. As this goes on, the nucleus itself, not only while herniating, starts to degrade, it not decompose, but actually changes its characteristics. It becomes more solidified. And also with this, the disc itself starts to lose height. The best analogy that is out there is that this is like a tire that has lost some of its normal air supply. If you say are driving on 75 at typical Michigan highway speeds and your tire is not sufficiently inflated, guess what's going to happen? Over time, you get wear and tear on the tread, you get wear and tear on the sidewall, and eventually you're going to get a puncture, you're going to get a sidewall blowout, your tire is going to burst. And something analogous to this happens with the intervertebral disc, because the next step in the process is you get an actual, what's called an extrusion of the nuclear material. This is where the disc herniates or slips, so to speak. Now, this previous slide was basically an up and down view. Here is an overhead view. You see on the right, you've got two types of discs, two types of bodies. The left part shows the normal disc. The AF means annulus fibrosus, or the tread of the tire. The NP is the nucleus pulposus, which using the tire analogy would be the air, but in this case we're talking about gelatinous material. If you get so much wear and tear that the annulus fibrosus starts to degrade, like the sidewall of a tire starting to shred, the nuclear material is going to push outward, and this is where you get actual irritation and mechanical compression of the nerve root. The nerve root coming off the spinal cord, going down into the leg. You get a chemical irritation, which causes one type of pain. You get a mechanical irritation, which causes another type of pain. And basically, this is where you get low back pain that is starting to move away from just the central low back itself. It may move into the muscle instead of just on the center part of the spine. It may move downward along the sciatic nerve. It may move into the buttock area, and this indicates disc problems. This is where you get the classic characteristic symptoms of low back pain. Now, there are some things that present similar to mechanical low back pain, whether it's from an abnormal lordosis or whether this is from a ruptured disc, herniated disc, or some sort of thing. And these are things that are known as red flags. The reason being, they're called red flags by the diagnostic physicians who have basically put this information forward, whose research is basically being summarized in this presentation. We mentioned that mechanical low back pain in 80% of the cases is going to be completely resolved and people will be back to normal within 6 weeks. If someone has a red flag, they may be presenting like low back pain, or it may start as mechanical low back pain that may resolve in 6 weeks, but other things are going on. And the reason why we call these red flags is because these can result in permanent problems. Most mechanical low back pain resolves completely in 6 weeks. If you have a red flag scenario, it's not going to resolve in 6 weeks. It may never resolve, and you may end up with permanent problems and permanent disability. The 3 major things that have been identified as red flags are something called the cauda syndrome. The cauda equina is the collection of the lower level nerve roots where the spinal cord itself tapers down into the nerves that pass into the legs. When these nerves are irritated, or you have the development of a caudal equinal syndrome, you can end up with permanent, what's known as saddle anesthesia. Think of, as you're sitting down, think of the area where you're sitting on as being completely, you can't sense anything. Or in a pardon the grammar, in a worse case scenario, think of pain in the area where you're sitting down that feels like it's burning and never goes away. That's what cauda equina syndrome can do. You may also get what are known as motor deficits, where muscle groups in parts of your legs don't work anymore. And we're talking about permanently not working anymore. You may have a permanent drop foot. You may have a permanent loss of sensation in part of your leg. And another situation with cauda equina syndrome is incontinence. You can't control your bowels, you can't control your bladder. And this is a red flag scenario that people need to be respectful of in potential cases of low back pain, mechanical low back pain. Another red flag is osteomyelitis. Osteomyelitis is an inflammation of the muscle tissue and the bony tissue. And this typically presents as a fever following a spinal procedure. So if someone has the characteristic symptoms of mechanical low back pain accompanied by a fever, and they've recently had a spinal procedure, and that doesn't necessarily mean spinal surgery. That could be a nerve root injection, that could be a lumbar puncture, that could be something as simple as a cortisone injection. If you're starting to see those sorts of signs and symptoms, that indicates osteomyelitis. Osteomyelitis is a difficult situation to heal and can result in long-standing and permanent tissue damage. And the final red flag would be the presence of mechanical low back pain that persists or intensifies in people who have a history of cancer, because this would indicate the possible metastasis of the cancer to parts of the lower back or to the disc itself. And these are certainly big-time problematic situations that need to be dealt with in terms of intense medicine and probably surgery. Okay, and this is where we get into some of the situations in terms of the current controversy dealing with imaging studies. And this is Kent being the messenger. This is not me coming up with some things, and so the old saying goes, don't shoot the messenger, please. You may agree with some of these things, you may disagree with some of these things. As I told the physicians to whom I presented this information, I'm not trying to tell you how to take x-rays. I'm not trying to tell you how to diagnose your patients. And for those of you who are patients or possible patients watching this, I'm not trying to tell you your doctor should or should not do this or things of that regard. I'm just trying to give you the current information out there from the American Academy of Family Physicians, from the American College of Physicians, and from the North American Spine Society. Their finding is that, and their suggestion is that in the absence of suspected fractures, obviously if someone hurt their back in a motor vehicle accident, there's a possibility of a fracture, an x-ray is certainly indicated. But in the absence of possible fractures, and in the absence of potential red flags, again, signs and symptoms that would relate to these red flag scenarios, advanced imaging, meaning CT scan, MRI, PET scans, other sorts of bone scans, are not really beneficial within the first 6 weeks of mechanical low back pain. Why is that? Well, if mechanical low back pain is going to resolve itself 80% of the time, why take the extra need, expense, and time of doing some of these higher level imaging things? It used to be, as early as 5 years ago, not so much a problem. Yes, MRIs are expensive, but insurance covered it. That is not the case anymore. And we're finding some folks who unfortunately experience the fact that, yes, they have an MRI, but their insurance doesn't cover it, or their insurance doesn't cover all of it, and they suddenly have a multi-thousand-dollar bill that they didn't expect to receive. That's the reality, unfortunately, in this age of healthcare. And regardless of who is going to be our next president in the very near future, that's probably going to continue for the foreseeable future because it takes a lot of time and a lot of energy to change healthcare and insurance regulation. Other findings from the American College of Radiology is that basically imaging's not needed unless there is no improvement after 6 weeks of conservative care, being defined as traditional medical care or chiropractic care or osteopathic care or physical therapy. So imaging, in the absence of definitive fractures, in the absence of red flags, is really not indicated until folks have tried at least 6 weeks of conservative care. Also, radiculopathy, pain down the leg, or early findings of sciatica is not an indication for early imaging because that, again, 80% of the time, it's going to resolve itself completely with no loss of function, no loss of anything within 6 weeks, 80% of the time. Now, again, that's 80% of the time. People naturally ask, well, what about the other 20%? That's where some of the degree of controversy lies, and that's where patients need to inform themselves about the limitations of things, and that's where physicians, chiropractors, physical therapists, whomever, need to stay up on the literature and up on the insurance information in order to help patients make informed decisions and not get blindsided by unexpected expenses. What also has been found by the American College of Radiology is that the early use of MRI seems to increase the rate of non-helpful spinal surgery. So while MRI can indicate a problem, sometimes folks forget that the problem's not a permanent one. Just like cuts in the skin heal and fractures of the bone heal, disc herniations can heal. Sciatic conditions, neuropathy conditions can heal. So if you take an MRI, it may show a problem, but that doesn't necessarily mean, oh my gosh, we got to surgically correct it. So again, it's not a perfect system, and people need to be aware of their options and their limitations. Now let's talk a little bit about management. Traditional forms of management have involved pain medications, things called physical agents, heat and cold, massage, traction, and rest, meaning no activity. The proverbial take 2 aspirin and call me in the morning, or rest in bed, and et cetera, et cetera, et cetera. We could spend days, weeks talking about the problems with pain medications and the opioid crisis and who's at fault and who's not at fault and whatever else. The one thing that has been found is that while pain medications may be helpful in taking the edge off, they may be helpful in reducing the level of discomfort. Pain medications by themselves do not take care of the underlying cause of the discomfort. So it can very nicely mask the pain, but until the actual generator of the pain is taken care of and the problem is reduced, that pain is not going to go away. It's going to come back. It's also been found that, if nothing else, let's step back just a moment in terms of a sidebar. I've been a physical therapist for almost 40 years. 40 years ago, you'd pop into a physical therapy clinic and you'd get heat or ultrasound or cold or massage and traction. And all these things very nicely help people feel better. But guess what? It doesn't they do not take care of the underlying cause of the problem. There is no data anywhere in the physical therapy literature, in the basic science literature, in the pharmaceutical literature, in the chiropractic literature, in the orthopedic or neurology literature that says heat by itself can reduce, can correct, can heal low back pain. The same with cold, massage, and with traction. I'm not saying that these are not helpful, but they're an adjunct. They're not the primary indication. These things by themselves won't take care of the process of healing mechanical low back pain. They won't expedite the recovery process. And then the other aspect of rest, unfortunately in this day and age, is not really an option. Pure rest itself has been found, uniquely enough, not to have any sort of effect in terms of taking care of mechanical low back pain. So, the traditional way of taking care of low back pain was rest. But interestingly enough, back in 1983, a physician, Dr. Richard Deo, at the University of Washington in Seattle, Washington State, published what's known as a meta-analysis. A meta-analysis is a scientific review of definitive published literature. Not speculation, not politics, hardcore truth and data. He found and first published in the Journal of the American Medical Association, JAMA, that rest is the single least effective treatment for mechanical low back pain. Rest promotes increased debility and disability. Controlled activity, which is basically what the contemporary term of rest means, meaning controlled activity, not the absence of activity, has found to be helpful for the remediation and relief of mechanical low back pain. This was first published in 1983, but it's been revalidated on an annual basis by a variety of different sources, both University of Michigan, Michigan State, Wayne State, Harvard, UCLA, you name the medical school, they do stuff on this and they have found nothing contrary to it. And this has been the case through the end of last calendar year. So if this is the case, the question I have, respectfully, is why are so many people resting instead of doing some things that will help take care of their pain? And the common natural reaction is, well, it hurts. Yes, it may hurt. Activity may hurt, but the real key is to find the balance between pain tolerable activity versus painful activity. So the traditional way of management has been on focusing on pain relief instead of the underlying cause, in terms of throwing medication or other sorts of things, or throwing hot packs or whatever else that may help relieve the pain for a short period of time. But until the underlying cause of the pain is completely remediated, the person is only going to have future episodes. The solutions have been to look at active interventions versus passive interventions. The idea of exercise as medicine. And several groups of physicians out there have said constructively, do something or continue to hurt. Patient, person suffering from low back pain, you can't just rest, because if you do, it's going to continue to hurt, and it's only going to get harder and more lengthy in terms of trying to get yourself better. You've got to do something, some form of controlled activity. So in terms of looking at things today, in terms of the contemporary perspective, we still need to look at controlling pain and inflammation, and usually this is through some degree of medication. But it's not just pain blocking or pain relieving medication. Pain medications, physician prescribed medications, are important, especially in the early stages of low back pain, or further on after, say, 4 weeks of that 6-week process, if things don't seem to be getting better at a definitive rate or a positive rate for improvement. What we're seeing here in the clinic, at least from the physical therapy end of things, is that physicians are prescribing medications for pain and for inflammation, and for some reason, patients aren't choosing to take them for a variety of different reasons. And we can respect that. But things that we hear in the clinic are, I don't like to take medication, or I'm afraid I'm getting addicted, or things of that regard. The medications that are prescribed today, in most cases, don't have those effects in terms of becoming dependent on it or addicted to it or what have you. If you do have a question, you need to ask your physician or you need to ask your pharmacist, because if there is a legitimate reason not to take them, then you shouldn't be prescribed them. But if you're prescribed them, your doctor, your pharmacist is trying to help you get better and is trying to shorten that period that's normally occurring 6-week period down into a much shorter period of time. So if the possibility exists of you having less pain, why not take that? That's where medications fit in this day and age. Early on, things need to be done to restore range of motion. That's what ROM stands for. That doesn't mean stretching like you've just finished a 10-mile race or a major weightlifting session. That means gently stretching muscles. That means gently moving joints. If nothing else, that means getting up off the couch or out of your easy chair and walking around a little bit to get some motion back in the system. Also, things need to be done to improve muscle function. This doesn't necessarily mean lifting weights or carrying things or whatever else. There's some very easy things that can be done that do not by themselves cause pain, that help with the overall recovery process. It's been found that mechanical low back pain has an influence on the nervous system as it relates to balance in the legs. Folks who have mechanical low back pain have been found to have problems with their balance. If you're older, above the age of 50, this translates into an increased risk of falling. And if you're above the age of 70, this increases the risk of you falling and fracturing your hip. So things can be done in the early stages of low back pain to help prevent these problems and to prevent future problems. It's also been found that cardiovascular improvement, aerobic sorts of things, we're not talking about riding a Peloton like you're training for the Tour de France, or cross-country skiing, or doing Zumba or things like that. But there are some things that do not hurt, that are very controllable, that help with low back pain, particularly through helping increase the rate of blood flow to the areas of the pain, which helps the healing process. And probably most importantly, are things to prevent recurrence. If you have a case of low back pain, it may resolve, but you may be at risk for future problems, especially if you're in an occupation where you have to do a lot of lifting and twisting, or you're in an occupation where you're subjected to vibration or things. So it's not just taking care of the pain, it's taking care of the underlying cause of the pain and then preventing or doing our best to prevent future recurrence of similar issues. So basically management today, and yes, I'm a physical therapist, and yes, if you come to me, you'll be seeking physical therapy services, but I'm not saying physical therapy has the answers. It does not. No single profession has all the answers for every single patient. So whether you seek services from a physical therapist or a physician or an osteopath or a chiropractor or a massage therapist or some other form of healthcare professional, make sure that what they're suggesting is based upon hard data, data-driven methods and procedures versus things that may make sense, or I heard this person do this, or this famous person does this, or I heard about this on the infomercial last night on TV. Make sure that it helps and has a track record behind it. Because if not, you're wasting your time, you're increasing your pain, you're potentially wasting your healthcare dollar. Also, patients need to accept responsibility for their own care and outcomes. By this, we mean when you come to see me as a patient, you're only with me maybe an hour or 2 hours a week or 3 hours a week or whatever else. They're 24 hours a day. It's very easy to undo the things that have been done in a clinical setting by simply not doing things that are appropriate for your own care when you're outside of the clinic. That's what we mean by taking responsibility for their care and your outcome. We're not saying you have to, oh my goodness, spend the rest of your life doing home exercises, and we're not waving your finger, you should be doing this or whatever else. But just be cognizant of the fact that it's your back, it's your pain. We can help you. We will try our best to help you, but any healthcare practitioner needs the patient to also help themselves. And the one thing out there that the variety of sources of authority keep trying to remind us is this final quote at the bottom: the importance of educating patients to understand that uncomplicated mechanical low back pain has a natural course, that being 6 weeks. We can't overemphasize that. So yes, it hurts. Yes, there's fear involved, but 80% of the patients who have mechanical low back pain are going to get better and remain that way and not have any long-standing disability or discomfort. So with that, just as kind of a reminder, I'm talking to you from our Bay Road location with Renew Physical Therapy. We have 14 locations throughout the Great Lakes Bay region, any of which would be happy to help you with your problem. And with that, I'd like to try to open things up for questions, if there are any, either through chat or relying on Kate back at our corporate headquarters to help us out, if there are any questions that we can try to answer.
Thanks, Kent. I think you explained it so well. We didn't have any questions come in today, but that was a lot of great information. Thank you for sharing it with us.
You're very welcome. Now, certainly this is an area when you talk about low back pain or anything in this day of healthcare, there's a lot of potential controversy. And I'm not trying to create controversy. I'm just trying to provide up-to-date information. But there's certainly ample room for discussion on various things. So if people do want to discuss something, if they have ideas, if they say, hey, Kent, you're completely off base, maybe you've got some information that needs to be communicated and distributed. So we're always open to discussion, questions, concerns, or whatever else.
We did just have a question pop up, Kent.
Oh, yes, go ahead.
Someone asked if there are any benefits to magnets, or is it just the stretchy band making it feel relieved?
Great question. You see things out there. There was magnets maybe 3 years ago were the great new big thing. And magnets themselves have been looked at. There's no data to support the use of magnets. It doesn't mean it's going to hurt. It may have a placebo effect, which means it may make you feel better without any sort of direct benefit from the magnetism itself. But anyone in healthcare will tell you that if you're having low back pain and something makes you feel better, and if it's not going to hurt you, go for it. Realistically, it's probably the compression sleeve that's holding the magnet, because compression sleeves can be helpful for helping with low back pain. What they do, and I'm not trying to say, oh my gosh, I got to go out and buy a compression sleeve, or I've got to go out and buy a fancy back brace, but some degree of compression through a compression sleeve or even a tight workout shirt or something like that can have some degree of pain limiting effects. It's not going to take care of the underlying cause. It can help you feel better as the underlying cause is addressed.
Great. I don't see any new questions coming in.
Well, if there are, or if you want to basically, again, either discuss some things or disagree with things, I respect that because, again, no one person has all the answers. Feel free to give me a call at the office number, or send me a fax if you're really into faxes, or send me an email. That's my email address. We're always hoping, we as Renew Physical Therapy, we want to help folks. It's not just saying, oh my gosh, come in for physical therapy or whatever else, or we have all the answers. We want to be able to be if nothing else, a good link to effective healthcare in the Great Lakes Bay region.
Great. Thanks so much, Kent.
Thank you for everyone who's participated, and we hope to hear from you soon. And hopefully we will continue to provide webinars that are interesting and helpful.
Great. Thanks, Kent.